Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on the newly approved Lenacapavir in treatment-experienced people with HIV. How should it be started? What are the practical considerations? To answer these questions, I'm joined by Dr. Darcy Wooten from the University of California, San Diego. For more information about Dr. Wooten and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Wooten has to say about Lenacapavir for treatment-experienced people with HIV.
There's a brief segment on Lenacapavir, which was recently approved for heavily treatment-experienced people. And so this is very exciting that we now have this Q6-month injection, which was just approved in December 2022. So at the time of this recording, we don't have a lot of real-world experience with this. And some of the challenges with Lenacapavir are very similar to those challenges that we see with other injectables like cabrylpivirine. There's the Capella study, which looked at the efficacy of Lenacapavir in really heavily treated treatment-experienced patients who had multi-class resistance. All of the groups ended up on sub-Q Lenacapavir plus an optimized background regimen. And the week 52 outcomes data show that even in these patients with a lot of resistance, rates of virologic suppression were really quite high. Even when patients had 0 or only 1 fully active agent in their optimized background regimen, there were still fairly high rates of virologic suppression. So this is a really great option for patients with difficult to treat HIV. It is important to note that there were some virologic failures with subsequent Lenacapavir resistance that emerged. This is not particularly surprising. 5 of the patients who developed resistance was really attributed to poor adherence to the oral background regimen, or these patients had really no active agents in their optimized background regimen. 4 of the patients, though, did go on to later suppress. So, this isn't going to be perfect for everybody, but it does open up a lot of treatment options for people who have extensively resistant HIV. There's 2 different options that the package insert and guidelines can recommend. The first option is a little bit more straightforward, and this is where patients receive on day 1 both oral Lenacapavir as well as injection. And then on day 2, another dose of oral Lenacapavir, and then you go to the Q6-month dosing, also obviously simultaneously on their optimized background regimen. Option 2 is a little bit more complicated, and so on day 1 and day 2, you receive oral Lenacapavir at 600 milligram dosing. Day 8, patients would receive a 300 milligram dose, day 15 injections, and then you go to the Q6-month dosing schedule. So each clinic will have to sort of sort out how they want to operationalize this and roll this out. And as we get more experience with this in real world, we'll have more information about barriers and facilitators to each of these options. But option 1, at least from my perspective, seems a little bit more straightforward and less intensive in terms of outreach and monitoring with patients as they're getting initiated on this therapy. Some practical considerations for Lenacapavir. The only thing I'll highlight is just that it's given subcutaneously in the abdomen, rotating sites, and injection sites are common. The big thing to kind of talk to and discuss with patients about are the development of nodules. The Calibrate study, which is looking at Lenacapavir in treatment-naive people, and this is an investigational use, so it currently isn't approved for patients, treatment-naive patients, but looked at a combination of Lenacapavir with FTC-TAF and then transitioning to either just TAF or bictegravir at week 28 in groups 1 and group 2, respectively, if patients were virologically suppressed, comparing to the oral regimen of bictegravir FTC-TAF. Rates of virologic suppression were comparable across all of these groups. There were 2 cases of Lenacapavir emergent resistance, and these both happened in the context of poor adherence to the entire regimen in these 2 particular patients, but this can, of course, occur. In terms of injection site reactions, I would just highlight as injection site reactions occur relatively frequently, 10 to 30%, but tend to be mild and don't lead to discontinuation of the agent. But the thing to point out is the development of nodules at the injection site, and that these can persist for a while. And so just something to have a conversation with patients about up front, so they're aware and on board through shared decision making if they're okay with that.
Thank you very much to Dr. Wooten, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program on the Clinical Care Options website, and to access the slide set for implementing long-acting ART in clinical practice, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.